Right. Well, good afternoon, everyone. My name is Dr. Melissa Bouchard, and I'm the founder of the ACHD Hive. Today, we have a very special session centered around women in congenital heart disease. I'm honored and privileged to welcome a group of inspiring women who are all leaders in the field of ACHD. Today, this roundtable discussion will initially start by exploring what made these women choose ACHD and why we think that there's more women in that subspecialty than maybe other subspecialties. And then the second part will discuss what were and still are the challenges for leadership positions in ACHD. So with no further ado, I'd like to open the floor to our esteemed guests. Please introduce yourselves. Now, on my screen, I will just have a look at making this bigger. There we are. So the first part, we're looking at women in ACHD and what is it about ACHD? So what made you decide going into adult congenital heart disease, and what do you think attracts women particularly in that specialty? I'll stop sharing so that we can all have a look at each other whilst we're talking. Who would like to go first?
I'll go first then, Mel.
Perfect.
Has to be someone, doesn't there? So I came across ACHD by accident. So I happened to be a trainee for a consultant who wasn't a specialist in ACHD but had an interest. And very quickly, I appreciated the speciality, although initially my exposure was limited. And I guess it was, for me, the holistic care of the patient. I always used to feel very unfulfilled to go in the cath lab, be involved in a patient's care and never see them again and know how they got on. And I think also the vast array of other specialists you work with. So you are part of a huge multidisciplinary team with the patient at the centre. So that is a very brief, I guess, reasons. There are multiple more, but I'll hand over to other colleagues about their journey, I guess.
I'm happy to talk. Thank you, Petra and Melissa. And it's such an honour to be here with this group. Thank you so much for inviting me. I'm Jolien. I'm a consultant in Oxford, and I'm also the chair of the Women in Cardiology Committee of the British Cardiovascular Society. I got into ACHD. I feel all of Petra's things also. I love the holistic care, but it was also, for me, I think it was that sort of sense that you could never be bored. Like it was just so fascinating on so many levels. And I think, as you alluded to, Melissa, in your slide, the importance of role models was huge. So I first met my colleague Liz Orchard, who's now my closest colleague. She was my consultant. She was incredibly inspiring. And then I went on Kate English's course. And then I remember sitting down with Sarah Thorne and Lucy Hudsmith and people at BCS. And I remember for the first time, I felt able to talk to those women about wanting to be a consultant and have a family as well. And that was huge for me, that it was just something we could just talk about. You want to have children? When are you planning on doing that? That it was just kind of part of the course and something that we could talk about. And to see people who had done it and who'd had children and were making it work. And that was a really important factor for me, as well as the other reasons.
Yeah, so maybe I can also join. I'm Jolien Roos-Hesselink. I'm a professor of cardiology at Erasmus MC in Rotterdam, and I was the chair of the ACHD working group of the European Society of Cardiology, and also had the pleasure to be in the guidelines. So I'm in the field already for a very long time. I started already during my training developing the interest in adult congenital heart disease. I like the puzzles. I really like to solving the problem what is going on? How is this working? This is really a sort of challenge for me. And then I went to my first Congress, which was on San Diego, where I met all the very famous guys like Joe Perloff and David San, Gary Webb, and well, you name them all. And I really was intrigued by their openness and their friendship and their really open mind to everybody. And I really had the idea that I could contribute in this field, because I think before my time, many developments happened in general cardiology with the introduction of the acute PCIs, etc. But in congenital heart disease, I had the idea that everything that I was doing was new. There was no good information on long-term outcome. There was no good information on how should we treat these patients, and can they participate in sports, and can they become pregnant, start a family, and I also, what already was mentioned, like the idea of following my patients. So they first come when they are 17, 18, and they have problems by the scar, and they're really worried to find a boyfriend or a girlfriend. And then a few years later, that's not a problem at all anymore, and they are starting a family, they're considering pregnancy, and then you grow with them during their deliveries, and afterwards see their problems when they have a reoperation, and you still follow them. And I also really like the psychological, mental part of it. So that's why I'm so really enthusiastic about this topic.
Hello, hi. Can I talk now? I'm Dr. Whaley. I'm a professor of practice at Imperial College. I work at Royal Brompton Hospital now. So I think I have been in this field quite long, not as long as Jolien maybe, but for all of you, has been rotated at Brompton. I think we have met before. I have to say, I'm a pediatric cardiologist, so I started doing pediatrician. As you can see, I'm short, small, and this is for the career. How do I choose your specialty? I have to choose pediatricians. Usually, it's a baby. You feel you are capable of handling them. This is why I did general pediatrics for 5 years and specialized in pediatric cardiologist. So when I was doing my MD in pediatric cardiology, I met Jane Somerville. She visited China. She came to my hospital in China. You know, we have really big ward with 50 beds, just babies with cardiac disease. So she came, she wanted to have a ward round with us. I showed her the ward. We have all sorts of patients. Some are operated, some are not operated. Then she said she wants to see the adult wards as well. So we went to see adult wards, and we have patients with pulmonary stenosis, I remember, and ASDs all scattered in the adult wards as well. She said, how come this patient in this ward and there is no specialized doctors looking after them? You know, that was in the early 90s. So ACHD, she called the Gooch, is so new, I never heard of it. Then she said, imagine all these babies you had operation here, where are they going? Who is going to look after them? You know, I was really a little puzzled. I thought, oh, they all had very good surgery. Why they have to come back? They go home or they carry on with their life. She gave us serious talks about ACHD, about Gooch specialty, why we need it. You know, she came with a mission, said in China, especially such a big country, you need Gooch. So at that time, you know, we don't have many people, young doctors can speak English, can communicate with her. So I was the one sent by my professor to look after her. We talked a lot. I showed her not only the ward, but also Beijing. We went to the market, antique market, you know. It's had a very good time. At the end, she really very, very serious. She said, you really need to develop Gooch. And we had a big meeting with the executives of hospital, decided our hospitals should send young doctors to be trained in England, because at that time, Gooch ward was established in London. She said, you can send young doctors here, get trained, then go back to develop. This is 91, and 2 years later, actually, I thought everything been forgotten. 2 years later, she wrote to me, she said, yes, now I have found the funding for you, and you can come. This is how I came here. So I came here, I have been involved in all the clinical cares of the patient. Also, I have, because I was a new doctor, I was sent to socializing with our patient. I went to Outward Bound with the patient activity groups, you know, as a doctor. But actually, when in the night, one of this Rastelli patient had palpitation, he knocked on my door. I was fast asleep, they said. And that experience, really, I learned a lot. I learned the life of our patient, and I learned how they coping with their conditions, and they really inspired me and encouraged me. And also, since I do the echoes for them, I find a lot of changes and a lot of problems never been taught, never knew before. So every time when I echo them, it seems adventure. I really enjoyed that. And also doing the echo, you can have a genuine talk with the patient, learn what's wrong with them. You know, often young patients, I see them before they get married, they bring their boyfriend, the next time they get married, then they get pregnant. And sadly, a few of them came crying. They lost their family, they got divorced, you know. We grew with them together. And the more important thing doing echoes for me is to see any changes in their heart. So I can foresee what's the forthcoming problems. And some patients tell me, sometimes I tell patients, I ask them. So the corresponding findings really encourage me just to say, okay, I got it right. This is what's happening. So often I remember patient heart, not their face, really. So this especially, I think, really inspiring for a woman. I think especially because most of us have families and have moms. It's the nature of the mother. It's like caring for your children. You want them to have very good life. You want them to avoid difficulties. So you not only know their physical problems, the psychological issues, and getting the insurance, getting the job, and you would like to be able to help. And you know you are able to help them or you are needed. It's a great comfort for me. So this is how I get on to the ACHD. Thank you.
May I continue? I am Magalie Ladouceur. I'm associate professor in Geneva, and also I work a little bit in Lausanne. And I was interested in ACHD because the first time I met a patient with this heart condition, she was a patient with a DTGA and a thinning, and she tried to catch the metro and run, and she had a syncope. She was hospitalized in the hospital where I did my training. It was in 2003. It was a long time ago. And I was very surprised because all my colleagues most of them male, did not understand anything about the physiology of the patients and why she did a syncope. And they told me, call the CHD center in Paris, because it was in Paris. And specifically, one of my colleagues, who was Dr. Isra, and when I discussed with her, I found thought about the anatomy, the physiology, the hypothesis of the syncope so fascinating. It was so different from the usual cardiology with coronary artery disease or heart failure. It was totally different. And I found it so fascinating. I wanted to do this. I was sure at the moment. Then I finished my cardiology training, and I could do also a trainee in pediatric cardiology, because it was not totally separate in France when I was trainee. And I found all the congenital disease fascinating with single ventricle, and I immediately see that we have a lot to learn from these patients, and specifically from teenagers and adults. And probably I grew with them because they had almost my age with their heart disease, and I grew with them as an adult with when I wanted to become a mommy, when I wanted to buy a house, when I wanted to do a career. I can make some parallel with my patients as well when I wanted to be more invested in sports. And I will see that we have so many questions about how we can care them. It was my first experience with ACHD patients, but also I have the opportunity due to my mentors that to have connection with other specialists in France and after in Europe, and also I can have some connection with US. And I discovered this huge world around ACHD. And as said, Jolien, with a so nice friendship connection, and so with collaboration on research. Also, when we want to transfer our knowledge, when we want to become mentor, we can now be a mentor for other trainees, and we can share this training between countries. It was fantastic for me. It was like a young girl in a toys store. I was so excited by this project. And it's why I decided to become an ACHD doctor. And I think also that many women are interested in its specialty, because this means that we need to have a lot of empathy for women who want to become a mother, but also for men when they have difficulties in their career, or with patients with disabilities. They need more time, more understanding about their condition. We have to help them to have a most normal life as adults, even if they have disabilities. It's why I decided to become a ACHD specialist.
Thank you, Magalie. Maybe I can add to that I completely agree and hear what you say. And I have another example of that I had to do a second opinion on women who were advised against pregnancy by male colleagues. And several of them I successfully could manage through pregnancy, and they now have 2 kids. And I think that changed their lives. And I'm sure that men have a somewhat different approach, being maybe a little bit more reluctant and caring for the mother's life, while we know that how important it can be also for women to have children. So that might also contribute. Yeah. Sabine.
Sorry, I'm probably the odd one out here. I'm an adult cardiologist, and my initial life for the first 10 years of my kind of post-university career was in Hamburg in Germany. And I happened to work, Joachim Hebe was one of my consultants, and he did a lot of congenital ablations at the time. And I remember some cases with him, Fontan cases. And initially I thought, oh, Fontan is very easy, just a big right atrium, nothing so difficult, it's easy to do it. Then I realized that Fontan is really the kind of the high end of everything, and any type really. And then Achim left our unit, I think 3 years into my training. And then it got a bit quiet about congenital heart disease. And I had basically, I wouldn't say forgotten about it, but it was kind of very rarely did we do an Epstein or something. And we were very busy, EP center. And by that time, we started to do a lot of AF ablation. I'm very much involved in the early works of AF ablation. Basically, my academic career in Germany relies on that. And I have a professorship on that in Germany for this. And we showed initially what doesn't work. And really as an electrophysiologist, and that's really what I think I am. I'm an electrophysiologist, I'm a rhythm doctor for all types of people. But at some point, 10 years into this or 9 years into this, I got a bit bored. And I thought, oh, I cannot possibly face 3 AF ablations or more every day. There's so many more AF patients than there are congenital patients, of course. And I got, for a number of reasons, I got a bit tired in Hamburg, and I thought I need to change location. I need to dare to do something I wouldn't ever thought of. And I happened to be asked to join the Brompton group. And I knew from the Brompton group actually only Professor Yen Ho, the morphologist, because I had visited them, that unit, in my first year of training for 3 days. So I had a bit of a notion about congenital heart disease from Achim working with Joachim Hebe. And then when I arrived at the Brompton, the best MDT by far was the congenital MDT on Friday morning. It still is my favorite, for sure. And I came on another important thing that I'm doing in my life, which is robotic navigation. And that actually is so elegant for congenital patients. And it seemed that at the time, no one really took care of those arrhythmias in those congenital patients. And I learned that most of them had atrial arrhythmias. Now I thought atrial arrhythmia is something that we can solve relatively easily. And magnetic navigation is an elegant tool because it overcomes access problems. You can get to into anyone's heart in any place. We're now starting doing procedures from the arm vessels. So patients don't get bed rest anymore. They're punctured somewhere here, and then they go home after a few hours observation. So we really try to make it easy for patients. And it turned out there were so many patients in congenital heart disease at the Brompton that just by the fact that I was there, I had this new robotic system, and they had no one else basically to do them. And I loved the fact that it was not AF. I don't have to vomit AF every day. So I had a very challenging cases. I love anatomy, a great opportunity to work very closely with Yen. I published a book with her about anatomy. I love imaging. This is another thing that we do, lots of roadmaps. I learned so much from Wei and work with Sonia Barban-Ryan, where we did 3D reconstructions of the hearts, and that helped me even more to do these interventions. And by now, I could say I'm an electrophysiologist with a massive interest in congenital heart disease. I wouldn't really say that I'm a congenital patient, physician. I learn with every case that I do, and I learn from my colleagues. But I'm a good rhythm doctor, so I think that's where my role is. And congenitals are just the best and the most challenging patients. And it's so gratifying when you sort their arrhythmia out. And then you can see that we can really do well for them. We can make them live long enough without arrhythmia. Ideally, if they're hemodynamically bad, we can make them live longer to live long enough to get a donor heart. Yeah, so that's a great opportunity. Otherwise, they would just not have that chance. And I think arrhythmia care in congenital heart disease is a big topic. You know, it seems like at least 40% of the patients have an arrhythmia problem. And that's where I think there should be even more of my type of doctors. You don't need to be congenital by training. I think you need to know your rhythm tools well and that part, and then everything else comes by getting involved. Do I see anything specifically female in this? I don't know. Maybe I like the riddles, everything that you all described, that you like the challenges, the understanding. But I think there is nothing specifically female in what I do. I'm a little bit more operational. You know, I love to see, of course, the patient doing well afterwards, but I'm not in this kind of decade-long care of patients. I come in, try to fix the arrhythmia, and then fade in the background, ideally. So it's a little bit more like a surgeon's role, maybe.
I just add something on from Sabine, Mel? I think Sabine brings up a really great point in advancement in care. And I think because we have unique opportunities with our patients and unique puzzles and challenges, I think that, is this a bit too extreme to say? I think we're kind of innovators, aren't we, in a way, in that we look at these problems and these challenges and look at ways how we may be able to approach that and improve the care of patients. And so, you know, the advancement of intervention technologies, as Sabine said, EP and device care, I think that's another thing that kind of continues your appetite, is this ever-evolving speciality, the opportunity to innovate, not only with, you know, procedures, but just innovating care. I mean, at the moment, you know we've got an aging population. So quite a few of us on here are adult cardiologists like you, Sabine, and, you know, we use a lot of our adult training in heart failure, in rhythm disorders, in palliative care, to then be able to kind of meld that with our ACHD. And I think that's a new kind of way of looking, and I think we've got a new paradigm and, you know, a great opportunity for people to train and to come along the journey with us. They don't have to be full-time ACHD cardiologists, but I think we can learn a lot from others, and to work in partnership with them.
Thank you so much. We're going to move on to the second part of the talk. I'm going to share my screen. So the second part of the talk, we'll be talking about leadership. And I'd like to introduce the concept of gender-biased discourse before we start talking about leadership. This is a discourse that I studied whilst I was doing a master's, and the definition of a gender-biased discourse is the societal prejudices against women, which end up widening the gender gap. And these could be, for example, the assumption that women are not as good leaders as men, that we're less skilled, less knowledgeable, and therefore that makes us less effective leaders compared to men. An interesting study compared 4 different groups: childless female professionals, working mums, childless male professionals, and working fathers. Interestingly enough, working mums were perceived as being significantly less competent compared to all groups. And their competence actually was perceived lower than their pre-child competence. Another interesting point was that working dads had similar competence prior and post having a child, but acquired more warmth in terms of reaction from the population that was studied. So moving on from that and taking that on, I wanted to ask if you felt the gender-biased discourse along your career. What were the challenges, and how did you overcome this? Did you overcompensate? Did you lead but either more like a man, or feel like you needed to be more like a manly leader? Or was it the other side, be more like a mother figure? And were there and are there any advantages of being female? So I'll stop sharing. Who would like to go first? Or it could be a flowing conversation.
I'll talk, Melissa. I'll say that I don't know if I thought about it sort of particularly in terms of being a woman, but I did feel when I came through doing less than full-time training, I absolutely felt a need to, I felt that a real sort of pressure not to mess it up, particularly for those coming after me. Like, I wanted to be a really good less than full-time trainee because I wanted people to think favorably about employing less time than full-time trainees in the future. So I did kind of feel that pressure. And yeah, and it is, and I think it is sometimes difficult when you are the only less, I think it's changing now, but if you're the only less than full-time trainee, you sort of you hold yourself to a high account, don't you? And it is yeah, it's difficult sometimes, I think. But I don't know that was specific to being a woman. I think it was more the less than full-time training. But I think what's really important is that we encourage men to work less than full time, that we encourage men to take up shared parental leave, because I think we need to move away from this sort of perception of childcare as a women's issue and childcare as being a parental issue. And so that's why what I always ask my male friends when they're having children, are you going to take parental leave? Are you going to work less than full time? And it's difficult because a lot of them, they say no, and I think they're worried about stigma on the other side of things. But I think that's the future I'd like to see, where it just becomes a normal thing that men and women do.
I'll come in next if people are happy with that. So maybe I was a few years behind Joe. Unfortunately, I was exposed to the some of the old-fashioned thoughts about women in cardiology. And initially, when you're quite a vulnerable young trainee, that can be quite hard. And so I recognise some of the things you said, Mel, in terms of overcompensating, putting off starting a family. Also, there was no real training pathway in ACHD when I kind of set off. And so in another way, you were quite a loner in that way. And so felt that you needed to put, having a family on the back burner again to be able to pursue that career. Also, I think we need to think of it in a wider sense of being a carer. So I was a carer for my mum, who was disabled and ill at that time. And so it's not only about children. And so you're right, I think you do overcompensate. But actually, as you get older, I think softening your approach and would I say using kind of female specific ways of doing things being a positive, not necessarily, but just accepting the fact that actually what was in the past gladly is vanishingly rare now, and actually, as you say, being that positive role model like Joe, saying it is okay to work less than full time. It is not okay that these old thoughts that are rare but are still there, these old messages coming through that you absolutely can start a family, you can live your life as well as being an excellent doctor and leader. Getting into leadership is another level. So I didn't kind of introduce myself. I've held a few national leadership roles and currently try and support NHS England in adult congenital heart disease issues. That can be another level of getting into senior leadership roles, whether it is within the hospital on exec teams or elsewhere, is still occupied a lot by men. And so, there are, in the same leadership in education, actually there's probably more women. Again, maybe it's because of the softer holistic approach, but I think that is still a challenge, and being put for promotion and things like that, there still is that financial and that senior leadership kind of bias exists. So, yeah.
Can I just say something? Obviously, I didn't get a chance to introduce myself. I'm not a medic. I'm not a lady. So what on earth am I doing here? It came across the Facebook feed, this event, and it took my interest. being a man on this particular subject, if you're uncomfortable and rather not have me here, by all means, I'm a patient known to Professor Ernst and Professor Whaley of many years standing, and I do find it a very interesting topic. And as a trustee of the Somerville Heart Foundation, when the subject came up and I had available time, I thought I'd join in. But if I'm in any way inhibiting any of the openness to speak, then please say the word, and I'm happy to depart and bid you on your way. But it's been very interesting so far.
Not at all. We want a man to hear us. Why we're only moaning between us? We want a man to hear this. Thank you for attending, really.
Well, that's an interesting subject, certainly.
Yeah.
For me, Michael, always nice to see you. Thanks.
Likewise.
Thank you. Yeah, maybe I can make a statement as well to this gender bias thing. It's actually quite interesting. I have 2 children, relatively recent, and I had a bit of a strange experience. I had the first pregnancy was during the COVID pandemic. Of course, that was very out of this world, very different. The second one was basically full back into normal life. And I have to say that most of my colleagues have been super supportive, very easy, even for coming back after the maternity leaves, kind of re-entering the normal service. I'm back. But I had some very strange comments. I had this kind of one comment that was, of course, never done in my face, but kind of I heard it through a third party that a consultant colleague, was worried if I had de-skilled. Now, I am a very senior consultant by now. I feel very senior. I'm very old. I'm an old mom. But I think if I would have been 10, 15 years younger, I would have felt threatened. If I would have been in my training and someone would have thought, oh, maybe she's not up to it anymore. And with all the hassle and everything else, you have to juggle so many balls. And I'm used to juggling. I can juggle a lot of things, but juggling with children is a different story. You know, they're between your feet, they do all kinds of things. But I think, you know, at the time when I heard this, I said, oh, that's a lovely comment. I even felt like, oh, he even bothered to think about how I was, you know, he didn't even care. You know, I interpreted it in a positive way. Afterwards, I thought, you know what? Why is he actually even thinking about it? I'm doing this for so many years. You know, it's like riding a bike, really. You know? But I think I remember when I was in training, even going on a vacation for 2 weeks or 3 weeks, I felt like my hands didn't feel the same way. When I punctured, I felt that I was worried. So being an old mom is a good thing in that respect, because you've just far more said that I'm so relaxed about it, and I loved it off more or less. But I think that it's different phases. So I wonder if one can generalize this kind of gender bias. I see from my patients, everyone is super happy that I'm back. They have waited. Some of them have said, oh, they don't want to see anyone else. You know, they were, of course, there were some pregnancy replacement for me. But I'm super happy for all the positive feedback that I had when I returned back to work. So I could say, not in my face, of course, you never know what's talked behind your back, but I had a very positive experience. And also in the kind of academic world, it was much appreciated when I kind of reappeared on the scene. You know, I think, and people are realizing I cannot say yes to everything anymore. I have more time constraints, but I think generally speaking, patients, that's my perceptions, are very, very kind. Colleagues, with the odd one out, are also very supportive. And it would be stupid, you know, if you think about the demographics of physicians, medicine is female by now, more and more. The leadership part, I think this is the last aspect maybe. There's not as much leadership yet. They're not as visible in the highest tier. And that has, again, that will change with demographics, I think. You know, I've applied for a number of senior positions, and I've always made second, always the runner-up, which is fine. You know, I don't mind. Sometimes I felt like the token female candidate on a panel, but also that is fine.
Yeah, maybe I can respond to that a little bit. I have also children. I have 4, but they're already a little bit older. They are now 20s and 30s. And when I told my boss that I was pregnant again, the reaction was like, "Oh, not again." Like I said, now you have to congratulate me instead of saying not again. So that was not the really nice response. So we started in the hospital this female network to try and empower our young colleagues. And we made some really nice baseline characteristics. We said there are so many women well trained. It would be really a loss of return on investment if you do not invest more on women. If you look into the high ranked businesses in the US, in the Fortune 500, in the top businesses, they do better if they have at least 30% women in the top. So these are really strong arguments in favor of having a good balance between males and females. And I'm also really convinced that it is much better. I think you do have some competences more related to females, and maybe you can not call it female, but female-like culture, like more social interest, more positive feedback, participation, teamwork, and maybe typical males are more action taking, more decision making, more competition. And I think you need both to have a really good, strong organization. And if you look into this way, you see the importance of having both males and females. And now it's sometimes even necessary to have more males in teams because we have a lot of females. On the other hand, I don't think that Sabine is right in her idea that if we wait long enough, we will also have more women in leadership roles. That really takes a different approach. It won't happen by itself. We really have to push. We have to help our colleagues to get a higher position. We really have to do our utmost best to be there. And it is partly due to the current culture, mainly dominated by males. Maybe they are a little bit afraid to appoint a woman in a position because they're afraid they're not emotional to do that. But it's also the women itself. They are more for the work-life balance. They are more like, maybe I'm not good enough. They're less self-conscious. So I always really think that we should empower our younger colleagues, that they should step in and they should take the role. And I'm really happy to hear that you are applying for the positions. I'm sure the next time you will be appointed, Sabine, because I think you're really very good. But I think it will not happen by itself.
No, you misunderstood me, Jolien. I think it will not happen by itself, for sure. You know, it's clearly shown that we need to, first of all, support each other. Yeah, so we see that in my EP world, it's about visibility, of course. There are few women. I was early on, I was frequently the only female speaker in a whole symposium on a whole day. And as soon as you are becoming a program director or a course director or something, and you can call the shots, and you can say, oh, but I know a good woman. I put some. Whenever I design anything, I have at least 20-30%, if not more, female speakers. Yeah, and that is something. And I also happen to have now a lot of female trainees, and it just happens that I seem to attract those. I also attract men to work with me. That's fine. But it's something that we need to leg up. But what my comment was towards this leadership position, you know, so how to become the chief of a service in a normal academic world, let's say a non-UK system, is quite different, especially if you want to have a work-life balance. If you have to leave because your childcare ends at 6 o'clock and you have to be home by 6, that's in a normal hospital very difficult to cope for if you wanted to be the lead physician under, let's say, the chief of the service. And that would probably preclude you from becoming the next level to lead your own department.
But males also have children, huh? So that's not a...
Yeah, but they don't do the childcare most of the time. So
they should. It should be 50-50.
Yeah, I know. But it's not always so easy. And even if it's kind of on paper or even verbally said, oh, I support you and I do everything, in the last moment, the last 5 minutes that count, for example, to show up here in time. Yeah, it's that last moment and that counts. And then that's the bottom line. You know, that's probably the last 5% that I may be missing with even the best intention.
Following on from what you're saying, my last slide, I actually called it women helping women, because I feel that it's so important, as you're all saying, that we should all be promoting and encouraging women to apply for these positions. And I noticed that even at our last conference, a lot of the interventional, maybe potential surgical lectures were all delivered by males. And so how can we promote that? I know role modeling was mentioned a lot, and it's very important. And also in academia, I've had some conversations about how many women can get to the professor level, and how can we all encourage that? And have you, in your centres, have you got something like a mentorship programs and things like that?
Yes, we do. We do have a mentorship program. It was funded in this female development program. And I think that's really helpful. And also, I think that we have to ask for it because, well, for instance, I was working 6 years in my current hospital, and my husband said, why don't you have a more senior position now? And I said, well, when the time is right, they will come to me and ask me. And he said, but well, you published in Circulation and you did a lot of education and you are very good in clinical care. So why are you still not appointed? And I said, well, okay, I will go to my boss and I ask him. And do you know what the answer was? He said, oh, are you still not in that position? Oh, you should have been already for 2 years. So probably we are also too modest and too shy. And our male colleagues would probably have come and asked for it already. So I would also try and encourage the young people to ask more for what they want.
I think following on from that also, I think you're right. There's often, one of the things which I found really helpful was there was an emerging leaders program that BCS ran. And through that, I was introduced to the concept of coaching. And that was really revolutionary for me to kind of think about the limiting beliefs that I impose on myself and, that stop me from applying for things and all the reasons I make in my head as, oh, I wouldn't get that or I wouldn't be good enough. And to actually try and kind of clear some of that stuff out of the way. And so I think coaching was really helpful in thinking how we can make that available to people, encourage them to do that. And I also think with the leadership positions, I agree, Sabine, with what you said. I think it is really hard to take on senior leadership positions and achieve work-life balance. And I do think also about job sharing, and a lot of these positions I don't know because I'm not as in one of them, but I do think certainly within our societies and so on, I think we should be encouraging people to go for these positions as job shares to try and make that something more achievable for people who are trying to do this juggle.
I protest.
Do you?
Yes, you can do it. Why not? I mean, all the males do it. It's just a matter of organizing. You should overstaff your household. You should be taking care that you do not have to do any work at home. You can focus on your children and on your husband and on your work, and not on all the different tasks that we are so obsessed with. And you should take the role. You can do it. I mean, don't be too 100% perfect. And I think we should do it.
I totally agree with Jolien. I think we women tend to be more modest, underestimate ourselves, and don't like to ask. Really, we really need to encourage each other and be brave and learn from our colleagues to put yourself forward. A lot of time, I think it's not the society or others put us down. It's we thought ourselves are not good enough. But through the two things, one is when I apply for the professorship, a second is apply for the national reward. I thought I'm not good enough, actually. It's my female colleague encouraged me, said, yes, put yourself forward. Actually, I got through with no problems. And now I realize we often underestimate ourselves a lot, actually. So we should encourage younger people and encourage our colleagues and to go for it, I think.
100% agree with what everybody has said. I think visibility of female leaders is important. Coaching is important. I think also, and building each other up is vastly important. But also I think it is being given that opportunity. So I won't mention the dirty word of job planning, but actually, if you are taking on additional responsibilities that are important to the running of a service, is for that actually to be recognised, so that you're not doing it in your own time, in the evening, on a Saturday, on a Sunday, which of course a lot of things we do, but actually that it is recognised and it's enabled. So I think that's important too.
I totally agree what you said about being supportive between us, but I found some limitation when the people who finally decide your promotion is a male. You have some men who totally support and encourage women to be promoted. I saw it in Switzerland, and I found it very, very nice initiative. But when I was in France, most of decisions concerning my promotion were performed by male, the dean as well as the head of department. And clearly they supported much more male than women. And I don't know how we can more support women to be leader and to be promoted and go on their career when finally they are male who decide.
I guess we have to challenge them, Maggie, and have our female colleagues support. So if a decision it doesn't look right, but like you say, that takes a lot, because if you get a knockback, that kind of bruises you, and sometimes you think, oh well, actually maybe I wasn't good enough, instead of going, or maybe not this time, or it's for other reasons. We tend to internalize it and go, there was someone better.
So I went to my boss and I said, well, you have this Harvard, this implicit bias test, and I want you to do it. And it's really a very simple test. And it's about, you have to divide cards. And on the cards, it said, for instance, a car or a computer or a doll or groceries, whatever. And you have to divide it between house and female on one side and males and career on the other sides. And the test doesn't look at where you put the cards, it's just how much time it takes to put the cards. Because the next test is that you have house and career, of a house and men at one side and career and female at the other side. And it's taking you 2 times more time to divide the cards to make a decision where this part belongs. And by doing the test, he realized this implicit bias. It's a really nice way to get the discussion started.
I think this is a really nice time to conclude. I think absolutely right. Discussions, communications, making a bit of noise, making some of these webinars, for example, that will be available for people to listen to. Role modeling is so important. Just like Joe, I started at the London teaching and saw these amazing women. I thought, I want to be part of your gang. And I think that is so powerful. And I think all of us have got that in us to inspire and pull up the next generation. So thank you so much for agreeing to come and have a chat about these really important topics. And I hope that we can all work, and we will do already, but all work brilliantly together. And thank you again.
Thank you.
Thank you, Melissa. Thank you all.
Thank you very much. Nice discussion.